Let's have the star of the evening, Prasanna, to show his experiences.
Prasanna will be talking about advanced glaucoma, right?
Sir, advanced glaucoma and MMT, more of 14-week follow-up is also having, sir. 108 eyes. I'll just touch upon that also.
Three minutes.
Yes, sir. Thank you.
Yes, sir. 3 minutes.
Thank you for the opportunity, sir. And as Arijit sir rightly pointed out, sir, in that study, it was done at a rural, it was done at an urban eye care center. It was done at Coimbatore. And we kept the compliance very stiff. If the patient missed one drop in at least 1 month, then the patient was defined as non-compliant. So that was the operational definition. So patients who are on 4 medications, they at least missed 1 drop in that particular 1 month. So that is why we label them as 100% non-compliant. So we were very particular about the study that Alan Robbins sir mentioned. If you miss 1 drop in 1 week, then you are missing 4 times in a month, and that becomes 4 into 12 per year, and that many days the damage will happen. So that was the idea behind doing that study when I was a fellow with my mentor Satyan sir. So thank you for the opportunity once again on advanced glaucoma and MMT. So some of the slides my senior speakers have already covered. So I'll try to keep it more practical with the objectives of these following 5 points. So in India, actually the problem is most of the times the patient presents in the advanced stage. So there is an imminent danger of patient losing their vision. So that is how we see the patients, right? In India, most of the cases are advanced glaucomas, and there are different staging systems which has already been covered based on Humphrey or based on definitions and severity criteria, or if you may be an octopus user. So advanced glaucoma is something that we have a near total cupping with or without severe visual field loss within 10 degrees of fixation. So that is how we see patients in India, and this is in UK and this is in rural South Africa, where you see in UK 38% and in South Africa 45%. And I think India is no less different, and most of us, when the patient presents to us, it's either moderate or it is advanced, unless we are going to strengthen our screening strategy. So if the patient is going to have an IOP of 21 to 25, within 14 years he is going to go into an advanced zone. If it is 25 to 30, it's going to be 6.5 years. If it is greater than 30, it is 2.9 years. So this is a time interval for them to actually go into an advanced stage, and there are many strong evidences towards advanced glaucoma. Like the strong evidence that is advanced structural and functional loss at initial presentation, a high or marked visit with IOP. So that's why we screen the patients with IOP. The moderate strength, we have disc hemorrhages, thin corneas, even it still has a role. And of course the African race, which we are not worried in India. So there are patient symptoms, there are secondary causes which we have to keep in mind when we are dealing with advanced glaucomas. Again, those are very important, and we assess the patient with structure function correlation, and always a careful inspection going back to the basic sciences, ISNT rule, and structure function correlation with fundus, OCT and visual fields are very important. So coming to this publication of mine, where we published it in AIOC2024, so not only in early glaucomas, but also in advanced glaucomas is where we were using the 10-2 visual fields. But this is something that 3 permutations and combinations I want at least the neophytes to take home. 10-2 is also important in early stages, where the defect will be seen in 10-2 but not seen in 24-2. Whereas you have another combination where the defect will be seen in 10-2 but may or may not be seen in 24-2, and then we have the traditional scenario where the defect will be seen in both. So again, this is a scenario where in traditional teaching it was thought if 24-2 is normal, you always don't do a 10-2, but those thought is changing, and always the structure function correlation holds well for every glaucoma that we see, and these are the 3 permutations and combinations that we tend to see in our practice. Right. So coming up to follow-up and aggressive IOP lowering. So that is what has brought us here to unite us for FDC. So many studies have come. Patients are not progressing, or patients do not progress if the IOP is less. And you can see Ortberg et al., EMGT. Many people have told that IOP, if you bring it down, the patients are not progressing. You can see that there is another study where if it decreased by 10%, each 1 millimeter decrease in mean IOP, the risk of decreased progression decreases. So everything is modifiable risk factors, and that is where we came to medical management, where my previous speakers covered on these slides, which I am going to skip. So if you are going to miss out on the drops, that is when the multiple single drug, multiple drug, double drug, I have no financial disclosure, but I have used Trisopt and the other combination of Dorzox T with a brinzolamide and a single drug of dorzolamide, timolol and a brinzolamide. So if you are going to give this or this, so studies have shown that the patients are going to prefer this for compliance and other issues. Right, so maximal medical therapy, moving on to the second part. So as Deven Tuli sir beautifully covered regarding all these combinations, and the triple drug seems to be working on all these 4 mechanisms of improving the aqueous outflow, the uveoscleral outflow, decreasing the aqueous humor production and whatnot. And this particular study, as Deven sir beautifully covered, where the IOP is reducing from 25 to 15, and these were the study that the company says, which sir has already covered. So let us come back to what we are doing. So this is a multicentric study. I am also on the board. So these are the 6 authors that we are taking it forward, and we are due for the results. So this is my data that I am going to share. The patient size, 107 patients have actually eyes, not the patients, it's the eyes. So the mean age is 61, and the pre-Trisopt IOP, as I would like to call, is 23 plus or minus 9.52. It's up to 33, 35. You can see the standard deviation here. It is plus or minus 9.52, and some of the patients I've also used, change them if they are on 3 medications separately, like dorzolamide, timolol and brinzolamide. I put them into 1 drop, so who I am seeing. So this is an ongoing study which we are doing, and I'm just sharing my half of my data, and the other authors are also compiling it. So the male and female preponderance, gender 47 and 53, and these are the patients. POAG are the predominant patients that are there in our data, and you can see that this is a pie chart of showing the same POAG. Severity of glaucoma, you can see 60%, so 60 eyes, 56.07% of them, we have taken them, or rather in our patients are more advanced. Again, that points out to the data that we were seeing in India, right? So severity of glaucoma were more severe, and those were the higher number of representatives in my data. And this is the pre-Trisopt and the post-Trisopt. So I have classified Trisopt as an intervention, like a trabeculectomy or a tube, right? Just like that. So drugs used pre-Trisopt, drugs used after Trisopt. So, and this is the table, the same data I have represented them in a table. So you can see that no drug meaning that the patient is actually on Trisopt. So this is before Trisopt, and this is after. You can see that even bimetoprost have come down, travoprost have come down, and even latanoprost have come down. So no drug meaning, I want you to get the message right, the patient is actually on Trisopt. I put the Trisopt as an intervention. So apart from Trisopt, the patient is not on any other drug. So you can see that certain zeros are there. But some of my patients, you can see, despite them being on Trisopt, they are using dorzolamide and timolol, and I have told them please stop it, because that combination is already, you are using it, and this is the last follow-up that I got. And then these are the number of bottles before Trisopt and after Trisopt. You can see again 0 meaning I put Trisopt as an intervention. So the number of bottles have come down in the rather 73 is only on Trisopt among the 107 that I showed the eyes. 73 are only on Trisopt, and you can see 1 meaning the patient is on Trisopt, and 33 of them are on prostaglandins. I see this number to be a very good number, because if you see it pre-Trisopt, it is 31. Post-Trisopt, it is 33. So it is like more or less the same. So it means that we are able to bring them into a single drug, and that is really looking like a game changer, at least the early results. Yes, irritation, there was one who complained that there was irritation in one eye, and duration of follow-up, it's too early to say, because I was lucky to start very early, and 5 patients, 2, 4, you can see that I have a follow-up of 56 eyes in 14 weeks. So this is my current data. Still 50 patients are due for follow-up, and this is a follow-up breakup, and this is a summary slide. Out of the total of 107 patients, 46 have attended the 4-week follow-up, and the IOP has come down to 16. So the 23-24 IOP has come down to drop of 8 millimeters, and out of the 107 patients, among 3-month follow-up, 18 have come far. So it's very new, right? So I have only a data of 18, and the graph is proving to be the same that the study has published. From 16, I am seeing a drop of 15. but the standard deviation is plus or minus 6.87. So that was one observation that I noticed from 4 weeks to 3 months. The standard deviation is slightly higher to 6 from 4. So this is the data that they also showed. I am also noticing something same. I think with time, if this improves to 6 months, 9 months, 1 year, 2 years, as Deven sir told, we have to see more how we are going to see this. So this is where I am standing currently with my data. So where do I see an MMT? So I think like MIGS, I think this also is this is already there, but how I see it as a mathematical equation is, if there is an advanced glaucoma, no AGM or on 1 or 2 AGM, definitely I would like to put them on an MMT and monitor them. If the patient is on MMT and he's still going to progress, then maybe I'll plan for a trabeculectomy or a filtering surgery. If the patient is going to be a cataractus patient, advanced glaucoma, if he's on no AGM or 1 or 2 AGMs, then I may go this route and then take the surgery, or I may go for a direct combined surgery as well, do a cataract and a trab. If it's already a pseudophakic patient with advanced glaucoma, with or without 1 or 0 or 2, then I may go for an MMT and then see how he's doing. Or if he's going to progress, then I'll go for a trabeculectomy. So I think MMT or the FDC, the fixed dose combination, this is where I see the role of it. So I just wanted to do a mathematical equation where we'll be inserting them into our armamentarium. And my results as of now, it seems to be similar to what the company is out, but I am waiting for my team members, where we are a team of 5 people who are collecting the data as we speak, and we are going to publish the study very soon. So India is going to be a scenario where it is advanced, and we are all seeing patients mostly who are at imminent danger of losing the vision, and we are going to regularly monitor them with 10-2 and with 24-2, along with a GCIPL and an RNFL change with the fundus photograph. And triple drug doses combination is a welcome option to achieve a target IOP, along with mostly compliance and cost of therapy, as Abhijit was actually saying. So once again, thank you for giving me this opportunity to share my data and views on advanced glaucoma and MMT. Thank you once again.
Thank you, Prasanna. I think exciting times, like I said, and your last study makes it even more exciting for the future. I think
Yes,
we
sir.
look forward to more of the overall
Yes, sir.
results from the 5.
All the other authors, yes,
And,
sir.
I'll request Abhijit to see if you can have more people. 5 is too less. So try that. You know, they are all young colleagues, and they are all energetic. They are all good. They are all well trained. So try see if you can have at least 10 people. Add 5 more to this, and it will be really great. We can have a presentation in Pondicherry, and Dr. Venkatesh is going to host us in the GSI Pondicherry in September end. That will be great. Anyone else in the audience wants to share their initial experience of this triple combo? Yeah, please sir. Sir, please आपका थोड़ा सा बताइएगा. Where are you from?
Myself, Dr. Venkatesh from Maharashtra.
Very good.
2 months before only I have started one patient. One I have already operated for cataract and trap combined surgery. For other I have started this tricept. He was on a multiple drug with multiple drops. Now he is happy with single drop, and the other which I have operated is also happy with that. I have started only for 2 patients now only. Another patient he comes for every 3 months. He still has not come. But this patient which I have operated, so in 3 follow-up, he is not happy with that one.
Sorry, what was the last thing? He was not happy.
Happy, he was happy with.
Okay. So all happy, you are happy, patient is happy.
Yes, I am also
So
happy.
3 of them, mind you, I also started very slowly and gingerly.
This is only 2 months started.
Yeah, 2 months. I started very slowly and gingerly. Like I said as a disclaimer, any new drug, we are very careful. But now I think we are writing it more and more. In fact, I like to share, I was in Bareilly about 6 weeks back for a CME, and there one doctor has used about 100. First of all, I don't know, it's not available so much in Delhi. I don't know how so much is available in Bareilly, but he says it's amazing. He has had no adverse effects and very good IOP lowering. And I'm sure, sir, which part of Maharashtra, sir?
Maharashtra, southern part of Maharashtra.
Sir, नाम बताइए ना जगह
Dr.
का.
Venkatesh Malge.
अरे
जगह का उदगीर.
उदगीर.
लातूर डिस्ट्रिक्ट.
लातूर बोलिए ना, लातूर समझ जाएंगे.
हाँ.
So I think it's great because you might be catering more to a rural or a semi-rural
Yeah,
population.
it's I am from Taluka.
And
And another one, Dr. Yashodan, he has also started the same thing for his patient.
Twice a day, 2 drops a day, if a patient is putting from a rural or semi-rural background, compliance is good, and the doctor is also assured the IOP should be good. And I think at less than 500, it's
Only for me from Taluka place, the price factor is somewhat restricted to all patient. I think the company will decide.
No, you should speak to him individually after this, sir. I'm sure they will help you. Any other thank you for your experience, sir. Anyone else wants to share their experience? So I think I'll just say one thing, that this is the first one. For me, the parameter for a good drug is that if one company has launched it, if another company wants to launch it, then I feel that's a parameter of success. And I was told recently, going through the exhibition today, that the second company, Indian company, is going to launch it probably in the new financial year, April or May. So that will be great, and I'm sure others will follow very soon. So it's a good initiative. Anything else, Abhijit, you want to add? Dr. Venkatesh, anything? All right, thank you.